Hey, everybody, welcome aboard and welcome to the new year. My name is John Sovic, and I am your host for our very first OutTalk of 2024. It's really great to have you joining us today, and I'm excited about our panelists and our topic this afternoon. For those of you who don't know, Outcare Health is an amazing organization, and one of our prime projects is the Outlist, which is a great place where you can find LGBTQIA plus providers, affirming providers, educated providers, people that can address the needs of our community. And if you are a provider and you're not part of Outlist, I encourage you to apply. It's a really, really wonderful way to resource into the community. Speaking of resources, also don't forget to sign up for OutCare's upcoming support groups next week. I believe next week we have a gender diverse community support group and an LGBTQ plus Black community support group. You can learn more about all of these things at outcarehealth.org. But with that said, I am so excited to welcome our panelists today. We've got some amazing people who are out working in the HIV and AIDS community, have not just current knowledge, but historic knowledge of traveling through this pandemic that's been with us for quite a long time. So with that said, I want to get right to our panelists, and I'm going to encourage them to introduce themselves, tell a little bit about who they are, what they're doing in the world. And their bonus surprise question they're going to hear for the first time right now is, who is a person in your life who has had an influence on who you are today? So with that said, let's start with Asia, if you're okay. Introduce yourself and tell us a little about who you are and your work.
Yeah, my name is Asia Sullivan. My pronouns are she, her, and I am a primary care physician assistant working in Los Angeles. Our clinic focuses on the LGBTQ plus community, and we do quite a lot of HIV/AIDS treatment and prevention. I'm originally from Alabama, and I went to school in Alabama. And I've been out here in the LA area for about the past 5 years now. I'm also an ambassador to the CDC for their Let's Stop HIV Together initiative, and someone who has inspired me and kind of shaped me along the way. I'm going to go with my supervising physician who owns the clinic here. His name is Dr. Kopani Vishney, and he kind of taught me everything that I know in this field, and we've been working together actually since I graduated PA school. So I'm going to go with him. So shout out to you, Dr. V. You're muted, I think.
And I am muted because I had a siren go by. So DeAndre, hello, how are you? Introduce
I'm
yourself to our
good,
audience.
John. Thank you. I'm no stranger to OutTalks. This is now my third time joining you all here, and I'm excited. It's always a great time. It's always fun. My name is DeAndre Moore, currently residing in Southeast Texas near Houston, little country town called Beaumont, Texas, on the border between Texas and Louisiana. I have a history of working in the field of working as a tester, mobilizer, advocate, and activist. And I'm a really strong champion for the U equals U movement, which means undetectable equals untransmittable, which I know that we will talk about later. Recently resigned as an employee from the organization that founded U equals U, which was the Prevention Access Campaign, where I now serve as a board member. Also serving as a board member to AVAC, AIDS Vaccine Advocacy Coalition, and as well as a member of the President's Advisory Council on HIV and AIDS. This is all due to my expertise and my experience in this field, but I always consider myself as someone who's always learning. There's always an opportunity to learn. Every call and every OutTalk that I've been on, I've always learned something and left with something. And so I hope that what's learned here does leave here today, and that we can inspire all of you all. The one person who comes to my mind immediately, I am a mama's boy, but it's my mama. She is everything to me. She teaches me how to be selfless. She's always giving and inspires me to give more, and just to help out other people, those around me. And just so full of love and just so inspiring to do whatever I can do. She's the one who told me that whatever I put my mind to, I can do it. And I'm crazy enough to believe it. So
Thank you so much. And Christina.
Hello, everyone. This is my first OutCare Health event, and hopefully it's not my last. Now, knowing that DeAndre has set the bar pretty high, being that this is his third time out here. So Asia and I, we're going to have to, step it up for sure. So again, my name is Dr. Christina Madison. I've been caring for those affected and infected with a positive status for about 17 years. This is my 20th years being a pharmacist. I started off my career as the clinical pharmacist embedded in a county health department, and that was really kind of where I cut my teeth in sexual health, HIV care, also helping with family planning, reproductive health, vaccination advocacy. And then I got credentialed with the Academy of HIV Medicine in 2013. So this is really something that is a passion of mine and has been since my training. I remember when people were still taking handfuls of pills, when we still had entire hospital wards that were just dedicated for people with AIDS diagnoses, and to now have people be able to take a medication once every 2 months is just kind of astounding to me. I always say that I'm hopeful that we will find a functional cure or some type of long-term remission for HIV within my lifetime. And I still firmly believe that. And I think that, as we discover new therapeutics and new means to help with the viral reservoirs that we know occurs during HIV, and then as we get more equitable access to preventative care, I do think that we can get to a point where this is something that we can look at as being in the past and not something that is going to negatively impact our future. And as far as someone who's positively impacted me, I will go with my grandmother. Unfortunately, she passed away during the pandemic. She was 91, almost 92 years old, but the woman was just a beacon of hope and light. And she always was so gracious with her time. And she always told me that you treat everyone the same, regardless of if they're the Queen of England or if they're the janitor. And I've really taken that to heart. And I just feel like kindness is something that you should always start with, and you should come from a place of service. And I learned that directly from her. And that is my Southern grandmother upbringing. Even though I currently live and reside in Las Vegas, Nevada, I think I'm a Southern girl at heart.
Lovely. Thank you so much. And once again, my name is John Sobek, and I'm a therapist and coach located in Pasadena, California. I am also the author of Out, a parent's guide to supporting your LGBTQIA plus kid through coming out and beyond. It was a really exciting process to bring that book into the world, and it's been received really well. So I'm just really, really proud of that. I've also worked in the HIV and AIDS community since about 1988. And I came into this work actually because my dad died of AIDS as a cisgender straight man, which early in the 80s was not a story, an expected story that you would hear in the crisis of that time. And because of his death and the journey he went through, that kind of awakened in me an advocate, an educator, that just like something's got to happen here, because nothing's happening out in the world, and we got to take care of each other if we're going to make it through this journey. And I never thought that I would actually live through two pandemics in my lifetime. It really was kind of shocking and stunning when I looked at our COVID journey and I realized, wow, I have lived through two pandemics in my lifetime. Never thought that would be a journey that I would go on. But I think the place that I think might be really valuable for us to start today, knowing that people who are joining us are all different levels of educational knowledge about HIV and AIDS, is maybe like, what do you believe are some of the common myths that float around about HIV currently, both in the communities and also in medical treatment? What do you think are some of the myths that are kind of affecting HIV currently? I see a nod from you, so I'm going to toss it to you first, if you're okay.
Yes, definitely. I actually see a lot of this both in my real life practice and online. I spend a lot of my time on TikTok, and I post a lot of content on TikTok, and the comments that I receive on those channels about HIV/AIDS just always astound me with how many misconceptions there are. And those are everything from, the ways in which HIV can and cannot be transmitted. I also hear, there's a big misconception that a cure exists for HIV now and that healthcare providers are withholding the cure, and, pharma is withholding the cure is something we see a lot. Many people are still under the impression that HIV is, a death sentence, or that you cannot live a normal, healthy, long life, after being diagnosed. So the misconceptions are vast and deal with everything from treatment to diagnosis to transmission. So those are kind of the things that I see pop up the most often, especially regarding, people will say that you can get it through sharing food and drink, or through kissing, or, that if you are living with HIV, you cannot have children, or just, lots of things. So those are the things that I've seen kind of pop up here and there, especially online.
Mm-hmm. Yeah, Christina?
Yeah, I was going to say the biggest thing that I see as a cisgender, Black woman is that my, being a woman of color, that HIV doesn't impact me, and that there's this thought process, especially because of the direct to consumer advertising for a lot of the HIV prevention and HIV treatment, direct to consumer advertising, is that it only impacts gay men. And so I feel like that's a huge misnomer that has really had horrible consequences, in particular in women of color, because of the fact that they don't have a perceived risk, and don't feel that that's for them, that they're like, oh, okay, well, I don't need that. Or, I always see the advertisements and I'm not a gay man, so I don't need that. And so I think that's one of the biggest misconceptions that I hopefully will do my best as I, talk about advocacy work and I'm out there and on social media, which, by the way, I'm so glad that Asia brought up her TikTok presence, because I do think that that is the future, is that we need to be where the people are, and where the people are on TikTok, and they're on the YouTube shorts, and they're on Instagram, and they're checking out those reels. And that's where people are getting their information. And we need to be where they are. And as healthcare professionals, we need to just swallow our ego and be like, no, we don't need to do little TikTok dances. No, you need to do a TikTok dance, because that's how people are going to listen to what you have to say. So
maybe we just need to do an outcare health dance,
or we could do that. I did a vaccination talk recently, and I was like, hey, let's get twerking for Tdap, I think we could do the same thing for HIV, right?
I
Come on,
like
guys,
it.
let's get it. Let's do it.
And Christina, you bring up a really important point too, because what you're talking about is a very Western centric look at HIV as well
It
too.
is.
Because you're right, the marketing was all done towards young, fit white men of a certain age group. But if we open up to the global story of HIV around the world, yes, women and women in communities of color and women in a poverty level experience are like the biggest population that was actually affected by HIV on a global scale. And that marketing, you're right, really changed the focus. Oh, it's a white gay man's disease. And I think that did a disservice to our ability to speak openly amongst communities about how we can move through this pandemic and through this virus. So
one other thing I just wanted to mention as well is, not only is the fact that it is this thought process that they're not at risk, but that also once they've become infected, that somehow that means that they are promiscuous, or that they've engaged in behaviors that are not, becoming of, being, a lady, or whatever they say. But the statistics do not bore that out. More than half of people and women of color who've been infected is from having one partner. So this is not you're promiscuous and you're going out there and you're engaging in multiple partners. A lot of times, especially because the male partner is not open about their status and the fact that they're engaging in same gender loving relationships, is why we're seeing these women who have a false sense of security that they're in a mutually monogamous relationship.
I think what you just said, to Christina, just to piggyback off of that a lot of cisgender heterosexual men can be honest about their sexuality, because attached to that comes HIV automatically. There's this notion that if you are a gay male, black, white, no matter what, the first thing that comes to mind for most people is HIV. I can remember coming out, as a part of my coming out story, just being a young queer person, was HIV. That was the biggest concern. But with that conversation, there were not enough conversations around opportunities to protect myself from HIV. In the South, especially in Texas, we still teach this abstinent only education. Hasn't worked, won't work. Trends continue. Young people still end up pregnant. Young people are still contracting HIV and other STDs because we're not providing the right education to people. There was no talks around PrEP. You know, I tested positive in 2014, and I had a conversation just a year before around what PrEP was. When it was out, things may have been different. The same thing around U equals U, just around healthcare. And there's this notion that for some people, the science works sometimes, but not all the times, because U equals U can't be valid. It cannot be validated. It's not true. But it is there. The facts are there. And just that we need people to understand that science is real. The facts are there, and there are a number of ways to prevent HIV in all of our communities, whether you are a teenager, young person, young adult, or whether you are well into your 60s and 70s and you still got those wheels rolling in the bed. Everybody deserves opportunities to protect themselves from HIV.
Mm-hmm. Yeah. You know, and one of the things that I think is very specific about this virus, and I like to talk about it in these terms sometimes, it is a virus. There are other viruses that people contract on a regular basis, and they go through illness connected to those viruses. But this particular virus holds a lot of shame and stigma about it. And I think it's important for providers to understand that, because that often gets in the way of these educational messages and in the way of initial treatment. And I was wondering if any of you could address that part of the puzzle as well.
Yeah, especially, you know, for healthcare providers, that's one thing that we are trying to encourage, you know, especially with the CDC's, you know, the CDC has a goal to effectively end HIV by 2030. And one way to do that is to get more providers involved in the conversation. And just like Christina was mentioning, you know, providers think only to offer HIV testing to folks who, you know, may outwardly identify as gay men. We don't tend to offer, statistics show that providers don't offer HIV testing and don't bring up PrEP to many different populations who could benefit from using it. And so one thing I like to bring up that the CDC has been promoting is the status neutral approach to testing and to patient care, in which, you know, literally any person, you know, like he was saying, whether you're a 75-year-old grandpa, whether you're a 13-year-old, you know, any person who walks through the door, monogamous, married, whatever, offer them an HIV test, talk to them about potentially PrEP and ways to prevent HIV, and know what to do next. So in case the test is positive, link to care. In case the test is negative, discuss PrEP. So that's what popped into my mind with this question.
Christina?
Yeah, I would just piggyback on that and say, and actually I'm going to go ahead and put a link in the chat for the attendees. It's a free testing initiative. Goal is to get out 1 million free at-home HIV tests in the next 5 years. And so again, I think the other thing too is when we talk about testing, we have to talk about looking at you know, testing from a trauma-informed lens and understanding that not everyone that is engaging with the healthcare system has had a positive experience with the traditional healthcare system. And then also that they may not be going to a clinic that is affirming, right? Or that feels like their choices, whatever those choices may be, is something that they personally agree with. But the problem is that we're not there to put our beliefs on our patients. We're there to listen, and we're there to be their guide with what is best for their overall health and wellness. And so I always ask that question, you know, what is your primary goal for today's visit? Because a lot of times what our goal is for their care isn't the same goal that they have for their care. And so we need to really think about this as a shared clinical decision-making opportunity, and people need to be engaged in the process. I like to call them activated patients, because those are the people who are going to take your recommendation and actually follow through. Because we can sit there and we can tell you all day the things that we think you need to do, but until you trust us and feel like we have your best interest at hand, you're not going to take my recommendations. And I think that's part of why we have challenges with HIV and testing, because the provider doesn't feel comfortable with HIV and testing. So we all need to get comfortable talking about sexual health, talking about, different ways that we can make this a positive experience, because when we help one, we don't just help one, we help many. Because once that person has a positive experience in our offices, that will make a ripple effect, because they're going to tell their friends, they're going to tell their family members, they're going to be like, oh, I went to this really amazing clinic and they were not shaming me, they weren't victimizing me, they weren't re-traumatizing me, they asked me about myself as a whole person, they asked about my lived experience, they empathized with me. Those are the things that we need to think about. And also, if somebody doesn't make the decision that we feel is the best for them, leave the door open that they can always come back. That's the other thing too. Not everybody's ready to make that decision on that day, and that's okay. Please leave the door open. Allow them to think, hey, you know what? I need to, do my own digging. I need to look into the facts. I need to go and see one of Asia's TikTok videos, right? That's I got to do. And then they can come back to you. So leave that door open. Have it be a two-way street.
That's one of the best things I think that we can push for providers to do, is to have that door open, and also to still learn from patients. There's a lot of things that are changing. Things are changing on the streets. And a lot of times the people that we cannot reach are those that people label hardest to reach populations. But those are the ones who are engaging in sex work. Those are the ones who are trans experienced. Those are the ones who might not make it as easy to come in and to just get that experience of holistic health from their healthcare providers. But that's because sometimes healthcare providers don't make it easy. They give them that quick 5 to 10 minute visitation that's not really making them feel as a person, but rather as just another number. You spend 20, 30 minutes in the waiting room and you get 5 minutes with your provider, because they've got to go ahead and go on to the next person. And I think we have to be more intentional as providers and as experts to allow space for other people to express themselves and be people, and also being open-minded, whether we agree with their lifestyles or their behaviors, their sexual behaviors or not. Our job, and the provider's job should be, is to give them the tools to make the best decisions and to have the healthiest experiences that they choose to have.
One thing I'm hearing from all three of you that I think is an important takeaway for any providers who maybe aren't currently educated in HIV care is, first of all, that education is really powerful. And at the same time, making it part of your community-based conversation, so that it becomes just a natural part of any healthcare setting versus some specific thing that is done because I may have had a sexual encounter that may have left me felt exposed. So I have to go in and get tested. And it's a fear-based thing. If providers can get educated enough to make this a regular conversation, this is part of your natural healthcare, then I think that's where potentially change can happen, especially on that grassroots level.
Yeah, sexual health assessment should be part of every health and wellness visit. It's not something that should only be done for somebody who is inquiring about HIV or HIV prevention services. It should be part of every assessment. I always say HIV care and PrEP care is not specialty care, it's everybody care, because everybody has sex. That's how we all got here. So it's time to take that stigma away and start talking about how we enjoy sex and how we can enjoy it safely and with as many people as we want.
Hmm. And if we were just going to kind of look, because I know all of you have so much of this wisdom available to you, where are we at as far as like communities that are at risk, that providers could be like, you know what, if I'm going to start somewhere, I want to start having this conversation more openly with these people who are coming into my office. Where are we finding our highest risk communities are currently?
I think it just depends on the region and when you are first. And what's the highest at-risk region in Texas is not going to be the same in Las Vegas, Nevada. And so I think it's about a matter of going the extra mile as providers or as healthcare workers to analyzing who is the population that we are not reaching, and who's being the most affected by this, and then going to be intentional about reaching those populations and seeing what they need. If it's sex workers, where are they? How do we find them? Where do we meet them at? Is it on the apps? Do we have to join some of these dating apps where they're meeting clients or whatever that may be? If it's people in the ballroom community who are struggling with homelessness, maybe we have to go out and be intentional and attend a few balls where we can go and reach people where they are, because they might not be able to work or have time during the daytime to go to the doctor's office or to have time to go to the healthcare centers. For me, it's about analyzing where we need to go and actually going out and meeting them where they are, intentionally and physically being where they are.
Mm-hmm.
Yeah, I would 100% agree with that. And also, give a shout out to telehealth and realizing that
Yes.
using telehealth and using home-based collection kits, that's something that my health department started doing, where they will send you a home collection kit and you can do self-collected testing for all of the bacterial STIs as well as a home HIV test. So I think, again, going back to the thought process around meeting people where they are, not everyone has a normal business hour job, right? So I work and live in a city where we have a lot of people who have shift work, so they don't have an opportunity to go to a traditional healthcare, system where it's open 8 to 5 because they work a shift and they are, they're asleep until like 4 in the afternoon because they have to get up and they work their strip job at 8 at night, and then they, sleep all day. So, thinking about alternatives to be able to provide equitable access, I think is really important when we talk about HIV care, because not everyone has the same resources that someone who either has shift work or a gig job, or somebody who doesn't have like a traditional 9 to 5 is going to be able to access the normal healthcare, facility. And so being able to mail people a home collection kit, being able to get free HIV testing, people being able to test in the comfort and safety of their own home, without stigma, without fear of judgment. Those are the things that we're going to be able to do in order to really move the needle forward. And then having an infrastructure in place that allows for that linkage to care if a test becomes positive or if it's negative, and now they want to take the next step to be on prevention medications.
Mm-hmm.
My colleagues, I was just going to say, I have no notes. My colleagues said everything I was thinking.
And for those of you who are listening to us live right now, I do want to encourage you that if you want to ask questions, we can throw them out to the panel. You can either use the Q&A function or you can put it in the chat. I'm keeping my eye on those spaces. If you do anything that comes up, please put them there and we'll do our best to address them as they show up. The other thing, go ahead.
I was going to double back on what Christina was saying about the whole telehealth thing. As a millennial, one thing that I appreciate about the pandemic is that it taught us that we absolutely can have these appointments just like this, very virtual. And my time is very valuable to me. If I don't have to sit in traffic, if I don't have to come wait in your waiting room, if I can be in the comfort of my home or at work or wherever I am and have this same 10-minute appointment right here, it's better for me. You're still going to get paid the same wage. It's all the same. Why not allow us to do that? I absolutely hate a clinic or a healthcare provider that does not allow for that option. I feel like they are behind on the times, and we are a space that's very technology driven and innovative. And that's one of the things too. That's how you help retain patients. Sometimes they can't make it in, but they might have 10 minutes to spare where they can jump on their phone, have a one-on-one conversation, tell you what's going on, and keep things going. So I encourage that all the way, and I push for that for everybody.
And one of the things that I think I would encourage providers to look at as well too is a few years ago, I was at a conference and there was a study they had done. I believe it was in Detroit where they ran this program. And they had created an HIV test van and they were going out into the nightclub areas of the city and saying free HIV tests. And nobody would come in the trailer, nobody. So they went back to the drawing board and they went out again and now offered free healthcare and diabetes screening. And people would come into the van. And then when they had them in a more private setting, they would say, well, while we're doing this, would you like to do an HIV test as well? And most people were very receptive to that presentation of being offered the test in privacy, but stepping into a van to get tested for HIV was an impossible burden for them to take on. And so providers, get creative, find ways to connect with your community in ways that are going to address what their fears and anxieties may be about this virus.
And my thing is, when you see that van, we all know it. Like, we know what that van is. We're out at the nightclub and you see this van over there, you know what's going on in there. And the biggest concern is when you get on that van for a person is, if I get off, are they going to be able to tell what I was just told? How can I fake it? What if I get on there and they tell me that I'm positive? How do I make sure that they don't know? And that can be one of the hardest things. I actually first tested positive at a nightclub, and I had to try to pull it together in front of my friends and like, yo, keep drinking, keep doing something so that they don't notice. And so, yeah, it was just, yeah, it's very hard to do sometimes. Oh,
Yeah, but that's just one example. How can people
yeah,
be creative in their communities?
exactly.
Like Christina is saying, how do you find a way to like work with the casinos to say, can we do a thing for your third shift people? To
Yeah.
look at this as a whole quality of life approach, not just, well, I'm open from 10 to 4 with a 2-hour lunch and hope you can fit in my schedule.
And if you're more than 15 minutes late, you have to reschedule later because you couldn't make it in time. So yes, that's all.
Penalize people for having to take multiple buses to get to their appointment. Like, what the heck?
God forbid. Gosh, yeah.
Sorry, don't mind
You're not
me.
even bringing them
That's,
to
if we can spend
soapbox.
all day on that alone, listen, that the access in itself is
Yeah.
just not, it's not equitable. I mean, healthcare is treated like a privilege in this country when it absolutely should be a human right. And so that's one of the worst things that I struggle with all the time.
We have an
I
interesting
agree.
question that came in, and I'd like to open up space for this if we can. So
Cool.
this from a therapist who works with many high-risk patients and people who are HIV positive.
Mhm.
And they were wondering, what are some of the biggest short-term and long-term mental health care needs for people living with HIV? So we're looking at the mental health care side of this.
Yeah, so the first thing is understanding that there may be some stress, like post-traumatic stress associated with the diagnosis. And then also with the actual act of taking the medication, because it is a daily reminder that they have this diagnosis. And so understanding it from that standpoint, but then also knowing that how they became infected is also potentially a source of trauma for them, because it could be from a sexual assault, it could be from a previous partner that now they're no longer able to maintain a relationship with that partner because they didn't disclose to them about their status. And so understanding like that initial diagnosis and hearing that diagnosis in itself is very traumatic. And then understanding that after that, there is long-term ongoing mental health counseling that needs to occur. One of the studies that I saw recently around the providers specifically talking about U equals U and telling patients about U equals U actually improved retention and care, as well as their ability to feel more comfortable disclosing their status to potential sex partners. And so I think as providers, we also need to think about ways that we can empower our patients to feel like they're going to be healthy and well with this diagnosis, and that they're going to live long, healthy lives, and that their life expectancy is almost the same as someone else without a positive status. And if we talk about that in the beginning, that really sets people up for success. It also, if we can do same day initiation of treatment, also does a lot for people's psyche, because one of the worst things that we did at the beginning of the HIV epidemic was that we would tell people to go home and think about their diagnosis, or we would like make them practice with like M&Ms with a pill case and all these things, all these ridiculous things. If we were any other provider, if we told somebody you have a diabetes diagnosis and we're like, you need to go home and think about your choices, we would be sued for malpractice.
Right? Yes, exactly.
Like, we would be sued. Like, that is malpractice. But yet we did this with HIV patients for years. We would wait until their CD4 counts went into the tanker, and then we're like, okay, now we'll give you some medicine. No, you need to do same day initiation. You need to address whatever the potential trauma was that got them to that point, at the time of diagnosis, and then give them access to ongoing mental health support after their diagnosis, and continue to encourage them to stay in care because they are going to live a long, healthy life.
I would also say ask the patient, ask the person, what do they need? Like, what do you need? Because we never know. They honestly might not know what they need. That's when you can start providing advice. But sometimes it's a matter of, what do you need? Is it just someone to vent to? And making sure that they are in a safe environment when they leave there. Because a lot of times domestic violence situations are linked to a person's new diagnosis, or to their diagnosis, or they're going home to a situation where they feel like that's all that they're worth. There was a time when, after my diagnosis, immediately, like, I thought I was stuck in the situation that brought me to having a positive diagnosis, and that I was not worthy of love from anybody else. Like, I had to be in this situation. This is what it was, no matter how toxic it was, no matter how much it hurt. This is all I had left, because I didn't have anybody to tell me otherwise. And so it's a matter of letting people know, and just pouring back into the patients, without having to get so attached, but letting them hear that they are still worthy, that they are a human being, and that, their lives matter, and they have something good still to do out there in this world. As long as there's a heartbeat, there's something there for you to do.
Yeah, I agree with those things. And I also like to encourage patients who may be newly diagnosed to find other people who are also living with HIV, or who have been living with HIV for a while. One thing I love about OutCare is those support groups, because a lot of times, especially, if you don't live in Los Angeles or some of these more urban areas, all you know of HIV and AIDS is what you've seen on TV, or these over dramatized representations of the illness itself. And people just, I would say many people, when they think of that, they don't think of just your average person who is healthy and thriving, and they're company owners and restaurant owners and doctors and lawyers and anything that they want to be, regardless of their diagnosis. So I always try, and one thing here that we have is kind of like a little group of people who we know, hey, can we connect you with this person? They've gone through what you are going through now. So I think when people have a community who understand how they feel, and who they can also see, thriving and living their best lives, that's does wonders for mental health. And so if providers are listening, one thing you can always do, in case you don't have that in your own community, is show them to OutCare.
I would also
Thank you. I could have said that better.
That's a really good plug. I like that. I would also say, though, I would even consider the family aspects. Ask the patients about what their family dynamic is. Are they going to be telling their family? Do they need help with that? Would they like to bring that family member in here with them? Because family support, in my experience, can make or break an entire situation. Sometimes family support, for me, I would always say my mom's love was a matter of life or death for me, because when I went home to tell my mom, I knew my life was going to go one or two ways. I was going to kill myself, or I knew that I would have a purpose still. And so, because my mom told me that day that she still loved me and that she was going to be here for me every step of the way, I knew that I was going to be okay for me. If it would have been different, I would not be here to have this conversation right now. But that was my purpose. That was my split road that I had to go down, and luckily it went to the latter. So.
Yeah. Thank you all for your expertise. I do want to make sure we make room today. DeAndre, you had brought this up at the beginning, and I think providers really need to hear this. We have an entire episode of OutTalk that does discuss PrEP and U equals U, but I think it's such a vital thing for people to understand, especially providers. I find, I'm in the middle of this work. I get this information all the time. I'm like, yes, people, this is it. This is how it works. And then you have a client come and says, oh, my doctor won't put me on PrEP because I'm this, or I'm that, or I'm not an at-risk person. And it's just like, that's not the point of PrEP. And so I wondered if we could open up some conversations first about the basics of PrEP and U equals U, and then maybe how we help providers move this more naturally into practice for all clients. So there's a big question. Who would like to maybe start the ball rolling just about U equals U and PrEP?
Well, I'll start. I'll just talk about the first and foremost, and by the way, the fact that you, DeAndre, talked about the fact that you were diagnosed in 2014, that causes me pain, because we've had a medication for PrEP since 2012. So Truvada came out in 2012 for HIV prevention. There were provisional recommendations that came out from the CDC specifically talking about who was eligible for it. So it was same gender loving men. And, that was like the very first one from the IPREC study. So that makes me painful. Like it makes me feel very painful that happened even after knowing that we've had this medication. And unfortunately, we haven't been able to utilize it as much as possible. We second medication approved for same gender loving men as well as women of trans experience, which was Descovy, that came out in 2018. And then in 2022, we had Apretude that came to the market, also available for same gender loving men and women of trans experience. So we've got 3 medications right now, 2 oral pills and 1 injection that can be administered every 8 weeks for HIV prevention. Of the ones that we have right now, only Truvada is FDA approved for cisgender women. However, there are some ongoing studies that are being done right now to really expand the use of Descovy as well as Apretude for cisgender women, because we do need other options, as well as some things like vaginal rings and other things that are in the HIV therapeutics pipeline. So that's really PrEP. So it's a medication that you take before sexual activity to prevent you from becoming HIV positive if you were exposed to someone who has an active detectable viral load. And I make that very deliberate statement because I want people to know that you have to have a detectable viral load over 1,000 copies to even get to the point where you would potentially even have the ability to transmit the virus to someone else. And you need to be engaging in barrierless intercourse. So that is not using any kind of barrier method. That's external condom, an internal condom, that's a dental dam, that's saran wrap, whatever it is you choose to use. But you are not using a barrier method, right? So if you're having an interaction with somebody and you're using a barrier, your risk goes very, very low. And then on top of that, we know that if your partner is undetectable, so the CDC's definition is less than 200, but most of the studies are less than 50, you have 0 chance of giving HIV to your partner sexually. And we know this from lots and lots of data. We're talking over 150,000 individual sex acts. So we're not just saying we got like a few people together and we're like, go ahead and have sex with each other. That's a lot of sex.
A lot of sex.
Zero transmissions. 0. So I want to make this. That's a lot of sex, people.
And all of that, and all of this is made public. So you can't be a medical professional and trusting science and not look at the science here, the research there, and not borrow that confidence. And if you won't borrow the confidence from us, look at Dr. Tony Fauci. I mean, the leading expert in infectious disease, who has said himself that the U equals U is the foundation. This is a quote, a direct quote, is the foundation of ending the HIV epidemic, but also the transmission, the risk is 0. It's not, it's there. And it's absolutely negligent to not share this education and information with your patients. When you know this and you don't do better and you don't share it, you're hurting the patient and you're hurting your relationship with your patient, because guess what? They don't hear from you. They're going to hear it on one of these OutTalk webinars. And when they hear from us, they're going to come back to you and say, hey, you didn't tell me this. And you're the expert. You're the doctor. I had to hear it from DeAndre, from Christina, from Asia on OutTalks. Like that there was a missed opportunity. And then now you created another level of mistrust between the provider and their patient. So you might get fired. And I'm one who advocates and encourages patients who can fire their doctors, fire your doctor, go find you another one. If you're not comfortable with them, please go get another one. But that's a little bit of level of privilege within myself that I know that I've been privileged to have. Everybody cannot do that. Everybody doesn't have access to do that. So don't make people even have to think about it. Just do our jobs that we're supposed to do and continue to help our communities by spreading this information so they can share it with someone else.
Asia, I'm looking your direction.
Yeah, I mean, everything they said, and we were talking about U equals U and PrEP and prevention, and I just wanted to make sure that also anyone listening was also aware of PEP, which is post-exposure prophylaxis. So in case you come across a patient or you yourself is not on PrEP, but may have had a significant exposure, or not significant, because who really knows, right? But may have been exposed to HIV. There's also PEP, and PEP is an HIV regimen. It's a complete regimen taken for 28 to 30 days. If it started within of 72 hours after that exposure, it is also extremely, extremely effective at preventing HIV infection. So just another tidbit, not only is there PrEP, but there's also PEP in case folks are not on PrEP.
And Aisha, maybe you can continue this conversation with this 2030 goal program. I'd like you to share more about that if you could.
Yeah, so the CDC has a lofty goal to end the HIV epidemic effectively in the United States by 2030. And so it is a big goal. We only have 6 years to get there, but many experts believe that it is completely possible. There's kind of 4 pillars to the initiative. It's diagnose, treat, prevent, and respond. So we want to diagnose all, ideally, folks living with HIV, because many people, the truth is that a lot of people in this country are living with HIV and are unaware for the reasons that we've all been discussing this whole time. So to diagnose, to treat, ideally, like Christina was saying, with rapid initiation. So the same day you get the diagnosis, you get that prescription for medications. To prevent through PrEP, which we've been discussing just recently, and then also to respond quickly to HIV outbreaks in various communities. And so the CDC and the experts who work there believe that, this is actually an attainable goal. And I would agree with that, especially if we do a good job in those 4 pillars and continue making sure that people hear our messages. They know U equals U. They know about PrEP. They know about PEP. I think it's not unrealistic.
It's not. Actually, just to jump into that, like there's an initiative that I created in my last job. It was called the Journey to 400,000. And that number 400,000 is the estimated number of people who are not into care or on treatment and who have not been able to reach an undetectable viral load. If we reach those people who are not in care, we get them on medications, which we need to do anyways, so that they can survive. If all of those people reach an undetectable viral load, I mean, you have zero transmission. There's nobody to transmit from or anything like that. So if we start prioritizing people living with HIV first and pushing the narrative that we need to make sure that they all get on care and give them the tools that they need to have holistic health, then we absolutely can do this in 6 years.
Yeah, one more thing I just wanted to bring up, because you talked about PEP, is I wanted to mention DoxyPEP. So one of the things that we know right now is that you are 2 to 5 times more likely to get and give an STI if you have an STI, meaning, if you have untreated gonorrhea or chlamydia or syphilis, you are more likely to transmit HIV. And so if we can get more people to do things like DoxyPEP, which right now is indicated just for same-gender loving men and women of trans experience. However, we do know that when you take just these 2 pills of doxycycline within 72 hours after unprotected sexual intercourse, that it can reduce your risk of getting these STIs by over 60%. And so that's another way that we can really start to chip away at some of these potential infection rates, because we know NIH declared, sexually transmitted infections in the United States a public health crisis in 2018, and we're still not doing very well. So we have a long way to go, and I think we just all need to get comfortable talking about sexual health, and we know that less and less people want to use a barrier method, and that's okay. We have other things that we can do other than just a barrier method, but we want to make sure that people are knowledgeable about all the different tools that they can use to protect themselves and to continue to engage in healthy sexual relationships.
And just because we're coming to the end of our time today, I always like to use this as our closing question. And just take a moment, take a breath. What for you personally is your vision or hope for the future of HIV care?
That's lofty.
It is.
I got my answer. My answer is always the same around a question like this.
Go ahead.
I hope to put everybody out of a job. If everybody's out of a job, that means that we have ended the epidemic. That means that we have done our jobs well done. And the shoulders that we stood on from the people from the 80s and 90s, they can sleep at peace. They can rest assured knowing that the movement that they started, that the blood, the sweat, and the tears that were shed in DC on the National Mall, that the fight from Ryan White and everybody else who came after them, that it was all worth it because we finally did see an end to this epidemic. And so now we got to go find something else to go and work for because we finished it here. This job was a job well done. It's taken us over 40 years, but we were able to do it. And so in my lifetime, I want to see a generation that does not know what a new HIV diagnosis looks like. I was not born, I was born into it. It's always been here since I've been around, but to see my niece or my nephew or even my kids in the future to know like, hey, that was something that happened in the past. That doesn't happen anymore. That would just chills. Yeah.
I would like to see HIV prevention therapeutics be as easy to get as birth control. Like, that's me. I'm like, birth control, plan B, that's basically what HIV prevention should be. I always say, just because HIV is at the beginning of the statement, it's still prevention. And we know that preventative care is extraordinarily impactful. Thinking about, you were mentioning that you're on a task force for vaccination. If we could get an HIV vaccine, oh my goodness, can you even imagine? Like, we wouldn't even be having these conversations anymore.
Oh.
So, and if we treated the medication like we treat a vaccine, and that we made it equitably accessible to everyone who wanted it, we would not be having this conversation. We wouldn't even be thinking about the 2030 goal as being unattainable because we would have already been there by now.
Absolutely.
Aisha, what would your vision or hope for the future be?
Well, what they said, and I guess my hope and my vision is that we do meet this goal by 2030. That's not that far away. It's only 6 years away. I think we're all in agreement here that it's possible. So that is my hope and that's my vision for the future. And also that, anyone along the way as we reach that goal who may be diagnosed with HIV can, shed any of that shame, internal stigma, and just feel comfortable and confident knowing that they are going to live long and healthy lives in care. So yeah, I hope our whole societal kind of, thoughts around HIV, both prevention, treatment, diagnosis, and the conversations just, become just something very neutral and normal, not shameful, not stigmatized, and just part of our everyday conversations in life.
Thank you. And I want to thank the three of you for taking time out of your busy schedules to share your wisdom, your knowledge, your experience with our audience today. And Asia, I have to know what's your TikTok channel so we can have people go see it.
Oh yes, please follow me on TikTok. If you're on TikTok, the handle is Couture and Clinic. Couture, like fashion couture, Couture and Clinic, all one word. That's my handles across all platforms. So yeah, I'd love to
And as
see
an
you.
equal opportunity employer, Christina, DeAndre, do you have TikTok channels out there?
Yeah, my TikTok is definitely not as robust as Asia's. I do a lot of posting on Instagram and LinkedIn, but I'm at the public health pharmacist. So all channels except for X/Twitter. I'm at public health RX, but that's just because I do media and that's where all of the news stations are.
Awesome. Same. I'm across every single platform at DeAndre B Moore. Just add a B as in boy in between the two, and it's all the same. So
Perfect. Well, once again, thank you all so much for taking time out of your busy schedules. And if you have any more questions, everyone, please feel free to reach out to our panelists. I'm sure they'd be willing to help in your education, and go to outcorehealth.org to watch a replay of this. It should be up in about a week. And next month on Thursday, February 15th, 6 o'clock Eastern time, 3 o'clock for those of us on the West Coast, our next talk is going to be about really approaching care with cultural humility and exploring the idea of intersectionality in client care. So we're going to have some great panelists there as well, and I hope you can join us at that time. Thanks all again, and have a great rest of your day.